The following podcast is part of a certified educational activity titled Everything You Need to Know About Biomarkers, Immunotherapies, Combinations, and Other Emerging Approaches for Lung Cancer. Access the entire activity and complete the post-test at peerview.com/WCZ860. Downloadable slides and practice aids are also available.
Hello, welcome to this program, Everything You Need to Know About Biomarkers, Immunotherapy Combinations, and Other Emerging Approaches for Lung Cancer. I'm Dr. Suresh Ramalingam from the Winship Cancer Institute of Emory University. Today, I would like to discuss with you some of the key updates and advances in lung cancer that were reported at ASCO 2020 meeting that concluded recently. Lung cancer has become a disease where individualized therapies are a reality now. Not too long ago, we were just using chemotherapy for lung cancers. And we use chemotherapy for small cell lung cancer. We use chemotherapy for non-small cell lung cancer. Over a period of 5 to 10 years in the 2000s, we learned the importance of the histological subtype of lung cancer and slowly ventured into molecular testing for lung cancer, specifically looking at driver mutations and using that information to make treatment decisions. So it was important for us to know that a non-small cell lung cancer was defined by the specific histological subtype. We wanted to know whether the patient had adenocarcinoma, squamous cell carcinoma, or large cell carcinoma, not just non-small cell lung cancer. And for patients with non-small cell lung cancer, the non-squamous histology, molecular testing is now considered an important first step as part of the diagnostic workup. This sets the stage for subsequent treatment options for that particular individual patient. So we highly recommend the use of molecular testing at the time of diagnosis for a patient with stage 4 non-small cell lung cancer with non-squamous histology, particularly adenocarcinoma. In squamous cell histology, we're making treatment decisions based on PD-L1 expression level. Sometimes, rarely, patients with squamous cell may have never smoked cigarettes during their lifetime. And for those patients, we do recommend molecular testing because it could represent a mixed histology tumor, and there may be a possibility that that patient harbors a driver mutation. For patients who don't have driver mutations, we now move towards immunotherapy as part of frontline treatment option. So we have targeted therapy, chemotherapy, immunotherapy, and some of the other targeted agents like anti-angiogenic therapy that are also available in our routine clinical practice. Clearly, the outcomes for lung cancer patients have continued to improve dramatically in some instances and modestly in many instances. How do we take advantage of these technological and research advances to make the best decisions for our patients? To do that, we will review some of the key data that helps us put perspective and additional information in the treatment algorithms that are utilized for patients. And when you look back at how immunotherapy has moved into the treatment landscape for non-small cell lung cancer, it can be described as nothing less than dramatic. Just about 6 or 7 years ago, we were using PD-1, PD-L1 inhibitors in late lines of therapy as part of clinical trials. Clearly, early on in the course of those phase 1, phase 2 clinical trials, we saw strong activity in a subgroup of patients. And that led to randomized trials, larger trials in the salvage therapy setting for patients with non-small cell lung cancer. So once patients had received platinum-based chemotherapy and had undergone disease progression, we used immunotherapy in that setting. And every one of the agents tested when compared to the standard of care at that time of docetaxel showed superiority in overall survival, and about a third of the patients seemed to have 3-year, 4-year survival duration, which was very exciting. So the immune checkpoint inhibitors became available as part of the second-line landscape for patients with non-small cell lung cancer. And then studies were undertaken to move them into the first-line setting. And a lot of the first-line development focused on patients stratified based on PD-L1 expression, a high PD-L1 expressing tumor versus a low expressing tumor versus the PD-L1 negative patients population. And various strategies have been developed for these patients. We have now drugs approved for PD-L1 high patients, pembrolizumab and atezolizumab. And when we say PD-L1 high, we're talking about an expression level of greater than 50%. We have combination approaches that have been approved for patients with lower PD-L1 expression, which is less than 49%. And more recently, we have had approval of combination immunotherapy approaches, ipilimumab and nivolumab. So all of these are going to help us make decisions for our patients as we move forward with treatment of non-small cell lung cancer. So in the frontline setting, the standard of care at this point for the high PD-L1 expressing tumors is monotherapy in most instances. Occasionally, we will give a combination of chemo plus PD-1 inhibition. We'll talk about that. When you talk about lower PD-L1 expressing tumors, there are a number of combinations: chemotherapy plus pembrolizumab, chemotherapy plus bevacizumab and atezolizumab, and more recently, ipilimumab and nivolumab are approved. Ipilimumab and nivolumab is also approved in combination with chemotherapy for frontline treatment. So a number of different combination approaches are used. The chemotherapy backbone for these patients depends on the specific histological subset if one were to choose the chemo plus immunotherapy approach. In small cell lung cancer, for a long time, we had not experienced much progress. Chemotherapy continued to be the standard of care, but more recently, we have had 2 immune checkpoint inhibitors approved in combination with chemotherapy in the frontline setting. The addition of either atezolizumab or durvalumab to chemo platform in small cell lung cancer patients yields an improvement in overall survival with a hazard ratio of approximately 0.75 and a median improvement in overall survival by approximately 2 months. While these are modest advances, they represent the first step forward in the treatment of extensive stage small cell lung cancer in a very long time. So we will talk about some of the developments in small cell lung cancer as well as we go through this presentation. As these key advances in lung cancer have happened, it has become critically important to include the patient perspective as we make decisions. We need to take into consideration the specific patient characteristics, patient comorbid conditions, and patient expectations. What is the patient really looking for with regards to a specific treatment approach that's being chosen? And to do this, it's important that we work together with our patient community. And from that standpoint, we're excited to have on board as a partner in this program, GoTo Foundation. They are a leading voice for advocacy and patient support in the lung cancer journey. They also support research, and they have participated or supported a lot of clinical trials that are being done nationally to develop individualized treatment options for lung cancer. So it's a partnership effort between the research community, the physicians and caregivers, and our patient community that will help us deliver effective therapies for our patients. So now I'm going to switch gear, talk about what we've learned from the recently concluded ASCO 2020 virtual meeting. We are in extraordinary times dealing with the pandemic, but we all know that cancer doesn't wait. Cancer needs to be managed, and our research and our patient care continues on without hopefully much of an interruption for a majority of the patients. So these important research advances provide us with timely insights into evolving treatment paradigms in lung cancer. The first concept I'm going to talk about is the combination of CTLA-4 and PD-1 inhibition, ipilimumab and nivolumab being the combination that's FDA approved. The rationale for using this combination is based on both preclinical and clinical evidence. In the preclinical setting, we've seen evidence that when we block PD-1 or PD-L1, CTLA-4, another checkpoint, is upregulated. So when we do combined blockade of CTLA-4 and PD-1, there is a more potent T-cell response against the tumor. After all, a whole purpose of immunotherapy in the context of PD-1 is to reverse T-cell exhaustion and maximize anti-tumor immunity mediated by the cytotoxic CD8 T-cells. We've also seen the combination of ipilimumab and nivolumab prove effective in the treatment of other cancers like melanoma and renal cell cancer. So based on these lines of evidence and early evidence that this combination worked effectively for non-small cell lung cancer, there have been phase 3 trials conducted. I'm going to talk about two specific trials that were reported at the ASCO 2020 meeting. The first one is a trial called the Checkmate 9LA trial. In this clinical trial, patients with advanced stage non-small cell lung cancer who were not previously treated with other treatments, in other words, first-line therapy patients, were randomized to treatment with platinum-based chemotherapy alone or 2 cycles of platinum-based chemotherapy in addition to ipilimumab and nivolumab. So in the experimental arm, patients got histology-based chemotherapy for 2 cycles. They also received ipilimumab and nivolumab, and once those 2 cycles were completed, they were continued on with nivolumab and ipilimumab. This trial was reported recently, and the results have led to the FDA approval. So let's review the data that led to the FDA approval of this 2 cycles of chemo plus ipi-nivo regimen in the frontline setting. The primary endpoint for this clinical trial was overall survival. And what we saw as in the presentation made by Dr. Reck from Germany is that the chemo plus ipi plus nivo regimen resulted in a very robust improvement in overall survival with a hazard ratio of approximately 0.66. There was almost a 5-month improvement in median overall survival. This benefit was seen both for squamous cell histology and for non-squamous histology. We also saw improvement in response rate with the chemo plus ipi-nivo combination. So the trial met its primary endpoint of overall survival, hazard ratio of 0.69, p-value of 0.0006, and this result was clinically meaningful for our patients. We also saw that the combination was tolerated well. The survival curve separated early and stayed separated throughout. So this trial is now has now led to the approval of this combination approach. One point I want to make also is that this trial included patients with both PD-L1 positive and negative patients. So if one were to choose the chemo plus ipi plus nivo regimen, it is effective in both PD-L1 positive and negative patients. I'll come back to talk about where I think this might help in our patient management in a few minutes. The second abstract I want to talk about is the Checkmate 227 trial. This trial is already familiar to this audience. This was a trial that evaluated the combination of ipi plus nivo and compared it to either chemotherapy alone or nivo alone in the PD-L1 greater than 1% population. And in the PD-L1 less than 1% population, ipi and nivo was compared to either chemo alone or chemo plus nivo. We had already learned from the publication in New England Journal several months ago that the combination result of ipi and nivo resulted in improved overall survival. The primary endpoint was for the patient population of greater than 1%. At the ASCO meeting, I had the privilege of reporting the long-term follow-up of this trial. At the time of this report, the median follow-up was about 3.5 years for patients on the trial. We saw that the 3-year overall survival rate with nivo plus ipi was 34%. This was similar for patients with PD-L1 greater than 1% and for patients with PD-L1 less than 1%. One of the other features of the combination of ipi and nivo is the duration of response. For patients treated with ipi and nivo, the median duration of response was almost 2 years in the PD-L1 greater than 1% group and 18 months in the PD-L1 less than 1% group. When you compare it in the chemotherapy group, the median duration of response was only about 6 months. So this suggests that the response you achieve with combination immunotherapy approach is sustained and durable, and hopefully this is going to lead to improvement at the tail end of the curve, which means long-term outcomes improvement for patients with non-small cell lung cancer. The combination was tolerated well, and most of the autoimmune adverse events were noted in the first 6 months of therapy. Once patients got beyond the 6-month point, the treatments did not result in any additional toxicities in a substantial manner. So overall, this trial showed to us again that the ipi-nivo combination was associated with durable long-term benefits. What else did we learn about immunotherapies in lung cancer? The NCI Canada group evaluated the combination of durva and tremelimumab. This is another PD-L1 and CTLA-4 blockade. This was compared to just the immunotherapy combination plus chemotherapy versus immunotherapy combination alone for frontline treatment. They showed that the addition of 2 cycles of chemo to durva and tremelimumab did not show an improvement in overall survival. Now, this was a smaller randomized trial. The main question here is the durva-tremi regimen has not been an approved regimen. It was an experimental backbone. So this study doesn't change in any way how we approach our frontline therapy patients. What about advances coming down the road? We all know that immunotherapy-based combination approaches are of high interest to broaden the patient population that benefits from immune checkpoint inhibition. A trial that I found very interesting at ASCO 2020 was a trial known as Cityscape, where the combination included blocking PD-L1 and another checkpoint called TIGIT, T-I-G-I-T. So a monoclonal antibody against TIGIT was combined with atezolizumab in frontline treatment of non-small cell lung cancer. The comparator group got atezolizumab therapy. This was a randomized phase 2 trial. And the signal appears to be that for patients with high PD-L1 expression, greater than 50%, the combination of the anti-TIGIT antibody and anti-PD-L1 antibody, atezolizumab, was associated with favorable outcomes. The benefit of the combination was not that pronounced, and in fact was relatively minimal in the PD-L1 less than 50% group. So I anticipate that these results will lead to larger definitive trials in an enriched patient population to see if a combination immunotherapy blockade approach will result in improved outcomes for patients with advanced stage lung cancer. So going back and wrapping this all up, when I have a patient in my clinic with stage 4 non-small cell lung cancer, what is my treatment algorithm? Well, this is what I do. First of all, I strongly recommend NGS profiling for every patient with non-squamous non-small cell lung cancer. And I suggest that we wait until the results are back as much as possible before we start treatment. If the patient is really sick and has to be started on some therapy, I would just start with chemotherapy alone, not chemo with immunotherapy for that first cycle. Once the NGS results are back, if they have a targetable driver mutation, they should get targeted therapy. And I want to remind our audience that there are 7 FDA-approved targeted therapy approaches for various targets in non-small cell lung cancer. So that's important. For patients who don't have the driver mutation, we look at PD-L1 expression. For those with PD-L1 expression greater than 50%, I prefer use of immune checkpoint inhibition alone. If the patient is very symptomatic and has bulky disease and performance status is declining rapidly, in that situation I would add chemo to the pembro or atezo. For patients with less than 50% PD-L1 expression or negative PD-L1, until now chemo plus pembro or chemo plus bev plus atezo has remained our frontline approach. Now with the FDA approval of ipilimumab and nivolumab, that's another effective approach. With ipi and nivo, the case to be made for their consideration is the durability of response and the ability to spare patients from chemo, so you have an additional line of therapy. When patients progress on ipi plus nivo, you can go to a platinum doublet. Particularly in the PD-L1 negative group of patients, the hazard ratio for ipi plus nivo is 0.62. So that approach merits our consideration. If you're going to select ipi plus nivo, and if the patient has very bulky or symptomatic disease, then one should consider the Checkmate 9LA approach of giving 2 cycles of chemotherapy. Now, these are for patients with good performance status. Obviously, we have to take into consideration the patient's specific comorbid conditions, whether they have prior autoimmune conditions, whether there are any other competing cause of mortality for that patient that would that would affect our decision to go with full court press approach. Regardless, the key is tailoring these exciting approaches to the patient sitting in front of us so we can get the best outcomes for our patients. What about stage 3 disease? Well, these are patients that have involvement of the mediastinal nodes, or contralateral nodal involvement, or direct invasion of the tumor into a major organ. Now, a part of stage 3A patients are surgically resectable. For remainder of the stage 3, we use concurrent chemoradiotherapy as the standard approach. More recently, based on the PACIFIC trial, durvalumab has been approved as consolidation therapy after completion of chemoradiation. So the current standard of care for stage 3 unresectable disease is platinum-based chemotherapy with concomitant radiation, and for patients who achieve benefit with that approach, to go on to receive 1 year of consolidation durvalumab. With that approach, we've seen improvement in overall survival and a 3-year survival rate of approximately 55%. What is the role of some of the other checkpoint inhibitors in this space? We learned about the Keynote 799 trial at ASCO 2020 this year. In this trial, pembrolizumab was given with concurrent chemoradiation and platinum-based chemotherapy for stage 3 disease, patients who are surgically unresectable. Patients with both squamous and non-squamous histology were included in this study. Pembrolizumab was administered at its usual dose. What we were encouraged by is the safety was very good. There was no additional toxicity with adding pembrolizumab to platinum-based chemo and radiation. The response rates were approximately 65% in the non-squamous group and approximately 57% in the squamous group of patients, suggesting that the combination is active. Now, there will be definitive trials. We've seen the value of pembrolizumab in another randomized phase 2 study in the consolidation setting. So this study shows us that pembrolizumab is potentially active in the stage 3 setting and merits further investigation. Now let's switch gears and talk about small cell lung cancer. I started off this session talking about the key advances in small cell lung cancer recently. We saw that durvalumab and atezolizumab are approved in the frontline setting. At ASCO, we learned about a phase 3 trial that involved adding pembrolizumab to chemotherapy for frontline therapy. The results were reported by Dr. Charlie Rudin from Memorial Sloan Kettering. This was designed in a very similar manner to the other trials that led to the approval of durva and atezolizumab. So patients with extensive stage small cell lung cancer that had not received any prior chemotherapy were randomized to cisplatin or carboplatin with etoposide in combination with pembrolizumab or placebo. The trial met its PFS endpoint. The median PFS was improved with the addition of pembrolizumab to chemotherapy. Hazard ratio was 0.75 and the p-value was statistically significant. The median overall survival, however, favored pembro but did not meet the statistical significance. The hazard ratio was 0.8. The safety profile was good and the responses were durable for a subset of the patients. So even though statistically the trial did not meet the overall survival endpoint, in my view, the results with pembro and chemotherapy are not very different from what we have seen with chemo plus durva or chemo plus atezolizumab. We also saw the results from another trial conducted by ECOG Akron, which was a randomized phase 2 study where nivolumab was given in combination with chemotherapy for first-line therapy. In this trial, patients received either chemo alone or chemo plus nivolumab, and then nivo was continued as maintenance. The hazard ratio for PFS in this trial was approximately 0.66, and interestingly, even the overall survival hazard ratio was 0.66. This was only a randomized phase 2 trial with 150 patients, but the efficacy endpoint favored the nivo plus chemo approach, both in terms of PFS and overall survival. So when you put the whole landscape of chemo plus immunotherapy trials together, now we're beginning to see some improvement in longer-term survival. The 2-year overall survival rate with the chemo plus immunotherapy approach across these trials is approximately 22-23%. This is an improvement over what we had with chemotherapy alone. The median overall survival now we're seeing is in the order of about 11 to 12 months with the addition of chemo to immunotherapy. With chemo alone, the median overall survival is still in the 8 to 10 months ballpark. So this, I think, is an important step forward for the treatment of patients with extensive stage small cell lung cancer. So in the frontline treatment, when we select patients, we do not use PD-L1 expression level to select who should get chemo plus pembro, chemo plus atezo, or chemo plus durva. It's given regardless of PD-L1 expression. Clearly, we need to develop biomarkers to help select therapy for those patients with small cell lung cancer that benefit from immune checkpoint inhibition. Now, I also want to remind folks that pembrolizumab and nivolumab are approved in small cell lung cancer in the third-line settings. Now, after first-line therapy for extensive-stage small cell lung cancer, we've had very limited second-line options. That has been a major challenge to the field. Topotecan has been the only FDA-approved agent, but there are limitations with topotecan. We know that it doesn't extend survival. It's only active for patients with chemosensitive disease, which means only patients who benefited from frontline chemotherapy have some evidence of benefit with topotecan. It is also associated with high level of myelosuppression. So for all these reasons, physicians have used topotecan with great degree of reluctance in the second-line setting, and there have been a number of ongoing efforts to develop effective options in the second-line setting. One promising drug that I want to talk about today is lurbinectedin. Lurbinectedin is an inhibitor of transcription programs. This drug has now been studied in a second-line setting of small cell lung cancer. There's been a couple of trials. What we have seen with lurbinectedin is that in the second-line setting, the objective response rate is approximately 35%. In chemosensitive patient population, the response rates can be as high as 45%, and in the chemorefractory patients, the response rate can be approximately 25%. Now, these are data from single-arm phase 2 clinical trials, but these results are interesting enough, and that have led to additional evaluation. At ASCO, we saw a pooled analysis that looked at efficacy and safety of single-agent lurbinectedin and compared it to a comparable set of patients treated with topotecan. And in this trial, we saw that lurbinectedin had a safety profile that was manageable. Grade 1 and 2 nausea, fatigue, and vomiting are some of the common side effects we've seen with lurbinectedin in these clinical trials. With appropriate supportive care, treatment can be continued. So hopefully that has been useful to you. We hope to continue to bring you these advances in lung cancer through various meetings such as this. I want to thank you for joining me today, and I wish you the very best.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/WCZ860. This activity is supported through educational grants from Bristol Myers Squibb, Jazz Pharmaceuticals Incorporated, and Merck & Company Incorporated. This activity is jointly provided by Medical Learning Institute Incorporated, Go-To Foundation for Lung Cancer, and PVI, Peerview Institute for Medical Education.